moment to have such a galaxy of internationally renowned faculty for this IAGS Prime Time. IAGS Prime Time has been showcasing the best of the talents from this country and outside of this country. Ladies and gentlemen, I'm going to be your host for this evening, and I take privilege in inviting Professor Sunil Papat sir, our President of the Indian Association of Gastrointestinal Endoscopic Surgeons. Professor Sunil Papat has taken over IAGS at the most difficult part of leadership in the presence of Corona and in the presence of multiple waves lashing us the scientific fraternity and the medical fraternity. He has been brilliant in crafting all the academics in a perfectly and distinct manner, and he has taken the tough time and he has contributed for the welfare of the doctors as well as for the patients by handling the COVID relief program, which has been successfully happening over the few years. Ladies and gentlemen, for those who are first time knowing about Dr. Sunil Papat, he has been a chairman of Nidhi Hospital, and he has very special interest on foregut laparoscopic surgery and has been an advanced laparoscopic surgery as well. He is also an ardent endoscopist and endotherapist, and he has benign foregut surgery as his principal core and concern. So, may I have the honor of inviting Professor Sunil Papat to give his welcome address. Over to you, President. Thank you.
Thank you, Dr. Kanagwal, for the kind words. Good evening, friends, ladies and gentlemen. I'm very excited to invite you once again for today's session of IAGS Prime Time. In a short while of 1 year, IAGS Prime Time has become one of the most popular online laparoscopic surgical program, not only in India, but also abroad. I'm very happy to welcome our past president and trustee of IAGS, Dr. Sandev Dasgupta, today as a chairperson. Distinguished faculty all across India and abroad, Professor C. Palanivelu, who is a laparoscopic surgeon beyond excellence from Coimbatore. Dr. Rajesh Bhojwani, our second chairperson, and he is from Jaipur. He is an advanced laparoscopic surgeon. And Dr. Senthil Nathan, who is an advanced laparoscopic and HPB surgeon from GM Hospital, Chennai. IAGS Prime Time was started last year by IAGS because of the COVID pandemic. We started online activities. And in last 1 year, we had more than 25 episodes with different faculties from India and abroad. Today, we are having the pleasure of welcoming Professor Palanivelu, who is not only famous in India, but all across the world. And last 20 years, I am seeing Dr. Palanivelu and he still looks the same. That's the secret of doing so many surgeries, he always keeps young. Dr. Senthil Nathan is also a leading laparoscopic surgeon from Chennai GM Hospital and has contributed a lot to the teaching and progress of laparoscopic surgery in India and abroad. I'm very happy to say that my dear friend Dr. Rajesh Bhojwani is taking over today as president of CELSI, the third laparoscopic surgery association of India, and IAGS is blessed to have founder president of AMASI on board today and current president of CELSI and IAGS and past president of IAGS. So it's a gallery of faculties, and I am sure this cohesiveness of surgeons across the board helps our colleagues, our junior colleagues, to enhance their knowledge and skills in the field of laparoscopic surgery. 2-3 months ago, we did a program on management of carcinoma of pancreas. At that time, our focus was on the management of pancreatic cancer. Today, We have invited Dr. Palanivelu to talk. Kanagwal, can you please switch off your audio? Thank you.
Yes, sir.
Yeah. So Dr. Palanivelu was among the first to do laparoscopic pancreatic duodenectomy, and I know that he has demonstrated it in Western countries also. He has so many firsts to his credit, and I'm sure Rajesh will introduce him in detail. But many of us have learned so many procedures while watching Dr. Palanivelu do the things. Once again, he is going to talk today on laparoscopic pancreatic resections. Our second speaker, Dr. Senthil Nathan, is going to speak of pancreatic resection in the second part of today's program. Without spending much time, I'll invite my dear colleague, Dr. Rajesh Bhojwani, to introduce formally Professor Palanivelu and take on the first lecture. Thank you.
Thank you, President. It is my responsibility and honor to welcome our distinguished colleague for the evening for chairing the first talk. Dr. Rajesh Bhojwani is the first qualified AMCH surgical gastroenterology super specialist in the state of Rajasthan. He has been passed out with outstanding records from Gwalior, later Gangaram Hospital, and then GB Pant Hospital. Setting up the first surgical gastroenterology department in whole state of Rajasthan, and he is instrumental in creating, and he currently is the head as a director of the Department of Surgical Gastroenterology, and has been training super specialty postgraduates for last 2 decades at the Sanktoba Institute of Digestive Surgery. May I have the honor of welcoming Dr. Rajesh Bhojwani to moderate the first session, and over to you, Dr. Rajesh. Welcome.
Thank you. Thank you, Dr. Kanagwal, and thank you, Dr. Popat, for inviting me over. Very good evening, all the viewers and listeners to the prime time. It's indeed my privilege to get this opportunity to introduce the biggest face of laparoscopic surgery from India. I remember when I was a student, when I was doing my MCH, he was the inspiration for me. And it is such an amazing fact to witness such an energetic person who has been inspiring 3 generations of surgeons, not only in this country, but all across the world. And he continues to do so. I'm sure this 2-3 minutes that I have to introduce Dr. Palanivelu are no way going to suffice his introduction. But let me bring up the salient designations that he has. He's the chairman of GEM Hospital and Research Center, Coimbatore, and also the professor and director of Institute of Gastroenterology and Minimal Access Surgery there. He's also the managing trustee of GEM Digestive Diseases Foundation, which is a charitable trust. All of us have seen him operating, demonstrating hundreds and thousands of times, and the entire world has witnessed that. It is important for all of us to realize that he comes from a very humble background, and I'm sure that inspires so many surgeons today as to how one can stay committed to and focused on his profession and reach the heights from nowhere. He is the face behind the laparoscopic revolution, and he is held in very high esteem by all of his peers from across the world. He has been a Dr. B.C. Roy National Awardee in 2006 and 2015. He was awarded by the House of Commons, UK Parliament, in 2018. He was the first Indian to win a silver medal in the International Olympic Minimal Access Surgery competition in 2009 in Phoenix, USA. He has more than 20 new operative techniques to his name, and all of these techniques are followed almost all across the world by various surgical societies. He has authored many books in surgery, and I'm sure each one of us has gone through at least one of his books at some point of time in our career, trying to shape and understand surgery, and particularly laparoscopic surgery. And he was the first Indian surgeon who was accorded the privilege to operate and teach in various countries, including the United Kingdom, USA, Hong Kong, Argentina, etc. Apart from these, he has a very strong inclination towards social and community services. And he has not only started a charitable trust, he has a very strong intention towards helping the poor. And he runs not only free beds, free mobile clinics, free ambulances, which help the downtrodden and the underprivileged society of patients in this country. And I think that that is something which is very, very peculiar and very deserves a very good respect from all the peers also. So, and there, apart from that, he has number of achievements and awards. I think it will take a long time if I go through all of these awards. It's a long, long list. And without wasting much time, may I have this honor and privilege to invite Sir Dr. Palanivelu to come up with his oration on the laparoscopic pancreatic surgery. Good evening, sir. Please come.
Yeah, good evening. Thank you, Rajesh, for nice introduction. And I thank Dr. Palanivelu and President of IAGS, Sunil Popat, and to make me to speak on today's prime time. And I think I'm very happy to be part of this. IAGS or Ramasi or SLC and India. We are Indian surgeons, wherever opportunity comes, sharing our knowledge, promoting. That is our happiness. And viewers are there, probably maybe students or maybe practicing surgeons. And today the title that, I don't know, Sunil Popat, I don't know why, how you chosen this. The title is a pancreatic resection. Is it conquered? That means still, is there a doubt? Or is there, it has been proved? I think it is. Okay, let me see somewhere, anything if a new science comes, all of a sudden will not take up completely. But slowly in phase of time, it will take over. And now, I think today, and 24 years, first Whipple done, 3 years completed. So first Whipple, after that 23 years, now journey is very big now. So that way, very happy that where we stand today, truly that minimally invasive pancreatic resection is going to be, or already we reached, or is going to be. I will share my slides. Okay. I have to go back, okay. So some slides I maybe because, and it says, when Sunil called, I accepted, suddenly forgotten, and today morning I just saw, then it is, the secretary called me, informed me. I think a laparoscopy when we introduced, and it was super gallbladder, and of course initially, then slowly appendix, later hernia. So many of the procedure, basic surgery for first 5 years, But cancer as such started even 91 itself, colon.
Sir, we can't see your slides. Have you shared it?
I shared it.
Okay.
Is it check it?
No, we can't see.
Okay.
Sir, Palanivelu sir, kindly unshare and reshare the screen, sir.
Yeah. Now I cancel. I will back again.
Yeah, now we can see.
You are good, sir.
Okay, right. So what we'll think, this is 30th year for me, laparoscopic surgery. And first 5 years, all basics. And cancer started in the early 90s itself, but was not accepted by many centers. And slowly, you look at particularly pancreatic cancer, 96 in World Congress at Philadelphia and Combined Sages meeting, Michel Garnier, a great surgeon, who said it is not helpful and there is no meaning of doing pancreatic resection and complications very high, it takes longer time. That's why he mentioned. Then that made me to come and do it, the world first people. Then subsequently when I showed in 2000 at Atlanta, and it was a great surprise for all the surgeons, pancreatic even reconstruction is shown that time. But you all know how much difficult people acceptance, people not accepted. So if you look at over these, pancreas, even the beginning open surgery itself, it is considered, is it resection going to help or better to do bypass, because to do resection, leak rate and bleeding very high. And that way, even that to look at that article published in early 90s, that was the trend that people talked about. Not only that, and these also two articles you look at, surgical treatment of pancreatic cancer was promoted like that, no? That laparoscopic. Russell in his lecture, the great surgeon, even 95 said, and question, same question of the 90s, that still it is evolving and cannot guarantee that cure can be done. But now you look at a lot of things happen. So let me go slowly that some of these, these things will share. So 98 we did it, and after that we was invited to Congress at Singapore also to present the master video. And subsequently, a lot of times, Olympic surgery competition, I was selected for only pancreatic cancer. And we have the great privilege doing the first RCT in the world, published in the British Journal of Surgery. Also, same one presented by Sindil during World Congress at Sao Paulo, and he won the best oral presentation award that time. Subsequently, confusion because who can, what, how, and what problems can manage. That's the first international summit. World Congress asked me to do it, so I did it at Coimbatore. That got published in the name of I will put it a play now. Okay. So that way it is, we are gone. Now we have guidelines we can implement. Anyone started. Now the way Rajesh and everybody is doing it, lot of young surgeons in India doing extremely well. I'm very happy. This is the first pancreatic Whipple. I did it in 98, and soon after his marriage, he had a jaundice diagnosis made, periumbilical carcinoma. Then he came to me, with the depressed. Then I did it subsequently, 2 children, and they are all grown up now. They are in the colleges. So, why this laparoscopic cancer particularly look at? The quality is better, immune is preserved, so that if you are minimally invasive any cancer, the chances of cure may be improved, and even recurrence can be minimized. That is a trend made me to do also to more in this part of this. Initial concern this when we moved to open to laparoscopy, they thought limited exposure, major vessels are close to it. If it bleeds, very difficult to manage. And at that time, initially, there was not much of sophisticated energy source was not there. But later it has come. Now we have a good energy sources. Totally, people can do it without transfusion, even hemoglobin normal. One needs to have a suturing, skill of suturing. That was at that time, everybody depended on clips and gallbladder clips. If a hernia doing it again, takers or these kind of things. People thought minimally invasive means it is a clips and the takers were the part of this. Initially, people never thought suturing going to. So, but suturing skill, if it wasn't there, then they can do more advanced. That is one we learned at the beginning at doing it. And after time going to be longer, even open operations of hours. So multiple reconstructions to be done. That's why everybody said, minimally invasive, is it first day you start, end the next day? That kind of things started. So steep learning curve, and oncologically safety was not proved at that time. So a lot of questions. But it is all gone through a lot of meetings and we made it up. And this is the first article, 42 cases when we published, that it made it a lot of things going. Then after that, you look at feasible and acceptance, not inferior to open, and it carries advantages. Then later it becomes standard of care. And a lot of articles all published in this from, and even the number of lymph nodes compared to open, it is not inferior. And similarly, that all lot of articles has come again that tumors and malignancy, duct carcinoma, all very much. Let me go that technique, and these are all the articles published by the various, and Kendrick and Kim, they have done a good number of work, and they here. Now robotic is doing, a Chinese guy is doing extremely beyond. So this is most important when you do and open or laparoscopy or robotic. If one can have a free survival longer than open, then it is definitely we have to accept. And if one can do less morbid, faster recovery, and with adequate cancer clearance, then we have to accept that is better than that achieved. That's why the longer progressions. And even number of lymph nodes harvest is better in minimal invasive, and our resection rate also lower in minimal invasive because of magnification, clarity. And that too, if now we have a 3D vision in laparoscope, 4K laparoscope, and robotic, if you go 3D vision, it gives an enhanced view of this field. And so clearance can be done much better. So it is definitely superior than open. And not only that, and now we have ICP, we can detect the tissue spread at the end of the resection. If any remaining tissues or nodal, if it is there, one can do it, clearance, that part. That's why now, and societies have discussed making it. So when this benefit is there, so that means we have to promote. So how to do and what are the guidelines? Subsequently now, and we had 3 international meetings, one in America, last couple of months back in Tokyo, and Asian Japanese Society did a consensus meeting. I'm also part of that, and now they made it each step what to do, everything. Now hereafter there is no question of only the learning problem. One has to learn and doing it. That way look at, and the standardization is most important. That's what I mentioned now. And everybody thought, no, open better. You can open and see. That's why 2013. But we made same screen, one screen open, one screen lab. Marcus Buchler, you all know, great surgeon, maximum work he has done in open. He did open, it was laparoscopic. At the end of the live demonstration, he himself said, technology is helping much more, magnification, everything. I do agree that laparoscopy is better. So subsequently, a minimal invasive pancreatic World Congress held, and postgraduate course held at Seoul, Korea, where I was supposed to be the chairman of that meeting. Subsequently, we did the first RCT and here consensus. So this last consensus standardization technique, and every surgeon has to go through these. Then finally, that he can make up mind and doing it. Okay. So this is a trial now published in BJs. Ours is the first one. Subsequently, Spain, the article has come, same RCT, in favor of laparoscopy. The third RCT has come from Netherlands. It's not RCT done. It was started, and after it was stopped at Belgium because of complications. Because unfortunately, the surgeons who were not adequate experience in laparoscopy, they started and finally they were asked to stop. So that RCT, we cannot take it. But still people thinking, they published, no? They used to call it. They look at pancreatic lymph node sampling, one can do very well in laparoscope robotic before going for a Whipple, or that way it is better. And so a lot of artery first approach has been described, and vessels reconstruction all done. Everything is much better in laparoscope than on. I will maybe show you a small video clippings. So even advanced portal vein infiltration by resection, it carries a very good result compared to without increasing morbidity. Yes, that can be done in laparoscope as well, robotic. If one fellow has got robotic, he can do reconstruction well. If it is not there, no problem, because a camera system also laparoscopy is very good. This is what I was mentioning, ICG, and we can have a very nice identification of tissues so that one can be sure at the end of the procedure RO. If it is extended Whipple, you want to do something for pancreatic resection, you can do it. If you want to do clearance of node, and can do. Even iatrocaval nodes, if it is positive, then you can take it up. That is all feasible now. And this is International Summit at Coimbatore. We held it and we published in Surgical Oncology as a Coimbatore guidelines. So this is the name. That's where when Japanese surgeon put it the title as the Coimbatore guidelines. So happy. And this is we made how to make it, make it better in minimal invasive. So proper indication in the beginning, resection technique, reconstruction. So everything is very important to proceed, just like otherwise making. These are the guidelines we brought in the name of TIPTI, and see all complete available. What size in the beginning one can choose, what location of the tumor, how to make it up, how to identify. So that kind of guidelines there, I do not go because it will take time, but everything, including patient's factor and instrumentation factor and technique, and even everything has been described in this article and published Surgical Oncology. And any juniors wanted to go through, they can go through this technique. And learning curve also, don't quote the beginning time, operative time longer. Even open it is longer. Even some surgeon taking 7-8 hours into open Whipple. So, but still today, and we also, live surgeries, many conferences we all have shown, but operative time is not that much. It is significantly reduced after 20 to 30 cases. So benchmark, initially when I started a pancreatic, I know that less than 5% of the tumor resectable and 5% of the people live. There was 90s. Now, and if we can perform RO resection, the 5-year survival is 80%. That means that something is very much impressive. That way one has to look at that, and instead of talking about the difficulties all. This is step-by-step description for Whipple, which in the video I will be showing it. And these are the certain of the techniques, my own descriptions, I will be showing video. And if you want to enhance clarity, that will make it sure, compare open, higher resection rate by clearance. These are things I described, 10 steps. Wide exposure. It is not that limited exposure, the wide exposure. One can do artery first approach, any type of artery approach can do it here as well, like open. And controlling the IPDA and VDA beginning reduces bleeding. And mesopancreatic excision can be done. Uncinate excision from the SMA very nicely can be done. And there are technical descriptions. And here also we described hanging maneuver, our own this one. And margin negative, one can do a perioperative ultrasound, or at the end of resection do a biopsy and go. Like, we describe this. If you do perfectly these 10 steps, there is no question to open or laparoscope or robotic. So minimally invasive, the laparoscope robotic is the way to do it. So, and I will go through step by step. These are the ports we place it for laparoscopic surgery. Camera port, generally when it is beginning, we all thinking umbilical is there, any surgery, gallbladder, otherwise go. Later we learned camera port can be anywhere in the abdomen, but only thing away from the diseased area to operate. So, and here will be head of pancreas and this work. So camera here, keep it uncinate excision can be done well. Here is a 12 mm, we can put a stapler, clip application, you can use right hand working trocar, this left hand working trocar. These are the two trocars. Initial or dissection, surgeon standing left side, one can do it. But most of the procedure I will do between the legs. And these are the not the trocars. These are the simple techniques I described for the liver retraction. I will show you it here. So these are the positions, comfortably one can do it. And see, this is a type of small, one can do it, lifting up the falcium ligament. And also gallbladder can be decompressed if it is, then put a loop, and that loop can be retracted by bringing through intercostals and leaving it as such. No need for any instruments. And otherwise, it will always come in a difficult. That's way very easily one can do it. Then you start proceeding. So you can, in a very nice way, and common bile duct dilated system are shown. So now I am going a step by step, somewhere description. And Rajesh, if you think time is done, you want to cut any time, you can tell me. So we gastrocolic momentum, open expose the head of pancreas, and we go to the left side, and here second part of the duodenum will show here releasing the adhesions, and finally, and the right colon completely mobilized down. Then we go to the third part exposure, and this is nice instrument, and we can use Thunderbit, or one can use Ligashore, one can use Harmonic, whatever energy source, it is okay. You can do it. And see, this kind of exposure is more important. Hepatic flexion should be down, so that we can go, extended coccus maneuver can be done well, so that very easily that. So next step. So now I am showing a coccus maneuver. So releasing the second part of duodenum from posteriorly. IVC you are able to appreciate here. And initially people thought coccus maneuver is a difficult one. That's why I used to. Even a choledochal system show, they will say, oh, coccus cannot be done and you cannot go down exercise. That is why now look at aorta. Aorta caval nodes, we take it for sampling. This is a nice harmonic, harmonic scalpel, one can do very bloodless. See, now we have reached the celiac axis SMA. This is the left renal vein. And you can look at any nodes here also, we'll take it sampling, frozen biopsy before proceeding it. In fact, SMA and the celiac lateral clearance can be done very well. As though you are sitting under the tree, like it is under the head of pancreas. Open people have to retract, putting a head down, seeing very difficult. Now look at everything can be done well. So this is where it is gives a very nice part of it. Okay. And now see, and now we have to suppose in case if it is SMB is partly null assessment resectability, one can work at the inferior border of the neck and look at the SMB and the portal vein. And the gastrocolic trunk has been clipped and divided. And this is a camera from the umbilical side down and showing now underneath. Instead of putting a finger and seeing, assessing it in open, here you use the dissect and see. Extended, even in splenic vein, you can assess, look at. Now, here again, the problem clearance of the common hepatic artery and the GDA control, for which if it is a periampullary, otherwise early lesion, divide the duodenum or stomach, whatever technique you want to do, classical or this, then you can go. But if it is otherwise, I complete the dissection incident can be done even before division of the duodenum or stomach. So now we divide it. So look at it, gives a wider exposure. One can perform lymphadenectomy. Now look at gastroduodenal artery. These are the surgeries shown long time back in a life surgery conference. And that's why the clarity is today a little poor, but recent cassettes would have been better. Now look at the portal vein is dilated. Common bile duct dilated. We work all around. And see, these are bipolar instrument we're going around. So what we do, this is endo-bulldog clamp, put it up, then divide. Now I'm dividing it, suck out the completely bile infected. And division should be cranial to the cystic duct opening. So endo-bulldog clamp. So we don't want the infected bile and spoiling the dissecting area. In fact, no. And periampullary always put a loop like this. The bile also should not come there. And so now look at. So it gives so much area one can work well. So now the portal vein, and we see this is a portal vein. This is a common hepatic artery, and we go clearly and all the nodes between the portal vein and the celiac axis and this. So clearance. And see uncinate. And again, this is all the small technique. Open also they will say smaller ducts, very difficult to identify. Same thing in laparoscope also. Initially, when we use energy sources and harmonic scalpel completely seals the bile duct. So this is a problem. So transpancreatic switches and upper and inferior border. This though call it hemostatic, but truly it is for handling the pancreas. See now, when we divide, see we know generally where the duct going to be, and that level don't use energy source. Just split the pancreas. Very easily can be identified the duct. That remaining parenchyma can use energy, but duct no energy closer to it, because if it is not in this one. See now these two sharp scissors without energy source. So now you can dividing it. So now look at, and DJ flexure has been mobilized and taking to the right side. And now jejunum is this side, so we make it a window. And we divide that to the right of this pedicle with the stapling. And see window, then we divide. So now I'm showing uncinate how to exercise. And this is, I have used my own dynamic traction. That's why nothing handling, but SMA you can see under the portal vein, it will come to the right of this. It usually left of the portal vein posterior, but this comes to the right side. See SMA, I'm not doing any retraction and myself, but already that head is been retracted, rubber band. That's why it is completely one can do. And you see, I'm looking for, and smaller vessels we clip it, and IPDA we can identify, put a IPDA, put a clip and dividing it. And open, very difficult to see these tissues. Here, yeah, see, this is superior pancreatic vein. And so we can put a capsular clip, hemolar clip and dividing it. Then is a replaced right hepatic artery, you can see, because imaging wise we know already. So no problem here. And even the clearance, you can do it at that level, take it out. See, look at, and this is. So anomalous vessels or replaced vessels is there in minimal invasive. After clearance, you see aorta, SMA, and IVC, renal vein, and portal vein. So this is where it is. So reconstruction again. This is the rubber band technique. I will show. I attach a rubber band on upper neck and here, also and inferior. And this rubber band will be taken to the lateral wall, and it will continuously, constantly give a traction. See, that is the way it is. So you can work in front and behind, and need not worry. The reconstruction again, and you can look at, this is where, see, through the pancreas, posterior surface, seromuscular, back again from posterior to anterior, and generally make it 2 switches cranial to the duct, 2 down, and duct to mucosa, and interrupted switches generally is the standard, but now we do continuous, and that's why I don't see any leaks nowadays. Look at the duct. You can, I think this also is shown in live surgery. Now look at. Japanese and some surgeons, Chinese, take a stitch in posterior. They don't want to slip, but generally we need only for few days. Okay. So similarly, 2 switches down, and finally we finished. Some hepatic duct we can do end to side. It is, one can use Vicryl or PDS, but I preference is always 40 PDS. Now, then during jejunostomy or gastrojejunostomy, it is surgeon's preference. It is both are standard technique. One can do it. Now 3 V-lock. I just showed the 3-0 V-lock, and this also can be done very well in bowel. Now accepted now. Okay. So I will go pass on some of the slides. It is okay now. See, this is again robotic, also minimal invasive only. Same exact technique, I don't change it. Robotic laparoscope, even open the technique is same. Only approach it differs, there. And I will show later. So if you do robotic, is there any advantage? Yes, it is got a full D. It will restrict in a hand, in a wrist like a movement, enhanced dexterity. Tremor filtering is not there. That is one advantage. Even you do a longer surgery, particularly when you come for reconstruction, most surgeons fatigue at that time. So again, ergonomically is very good and supports. And this is already shown. I'll show. I think I will show later. I think same technique. I don't take. So the 3D vision, magnification, enhanced skill. This is where it comes more important. And if it is there, I will show external coccus and robotic can be. So assist surgery improves performance of surgeons, enhance surgical skill, IT information, all the whatever investigations, whatever you do online, real time, one can do it. Mentoring easy. So that's why laparoscopic robotic, it is compared to open, it much more. There, of course, bleeds, open surgeon can put a pad control it here, it's not there. But this is technology making it. Robotic, if you look at, one finger is equal to one hand, like double, and it makes it totally multiple enhanced performance by this technology. And but robotic conventional laparoscope assist, lot of articles came, but till now the results outcome is same. So if one is not having a robot, need not worry about, continue to do laparoscope, and results is time being is better. Some surgeons claims it will a short stay or not, and easy to reconstruct. That is the only thing it is here. If a duct, pancreatic duct is not dilated, soft pancreas, I may recommend a robotic as a first choice. Rest of the places, surgeon choice, one can do it. And oncological outcomes, and it is also assessed and laparoscopic, and I think that studies, So no difference between a laparoscope and robotic time being. Postoperative variables is same. Intraoperative variables is also same, including blood loss, everything. And it is a pancreatic pulse is always considered a dismal prognosis, oncological. That's why very important is one has to do without compromising the quality. Then it is fine. Technological assistance is very important. And initially, yes, we did not have that instrumentation and energy sources. Now we have everything. So that way the benefits of minimal invasive and without opening abdomen, without giving a transfusion, it is immune preservation helps us to have a more success rate. And long survivals, when you look at, and less trauma, sharper dissection, reduced pulmonary complications because absence of abdominal incision, and blood transfusion rarely we give it at all normally. And adjuvant therapy immediately can submit. If it is peritoneal nodules, need not proceed surgery, put it chemotherapy, then take up surgery later. Now we have got a very good chemo system and chemotherapy downstage and get it surgery also. So this is very important part, and these are a lot of articles has been published. So decreased blood loss, short hospital stay, these are all things one approved. And also less pain, shorter. Again, the articles shown advantages for minimal invasive. So ICG, again, I already told two things. One is cancer cell spread you can assess, and IPDA, replace hepatic artery, one can very well assess. And in fact, without careful dissection, because magnification, one can do well. These are things. Technical feasibility, and we developed our own dynamic traction, first caudal vein. Lot of techniques have been described by many authors and gonna make it up. So technical feasibility is again shown, and future and Whipple operation. If you ask me, is it going to be open, laparoscope, robotic? I will definitely say minimal invasive. Why? If we have a robo, if a patient is affordable, is keen to have, we can do it. Otherwise, laparoscopy, we can do it, give the benefits, and minimal invasive. But in future, and all surgeons must be trained well to do minimal invasive. There is no point now, easy to do it surgery, fastest you can do it, and comfortable. No, patient's sake, if a surgeon can put more effort, learn, even difficult, learn the best and do the better. So these are the things, why technology, it is augmented reality. Artificial intelligence already is coming into picture. Now single port surgery, robotic single port surgery is Whipple is very well. And so surgeons' capability increases. Surgeons have a limited power. You cannot enhance power. But if you make it robotic instruments, your power is enhanced. So, but a lot of newer refined instruments are coming. And future, Japanese surgeons have made it next 5 years. They want to connect all the OTs in all the islands as a single OT. Why no? They can guide. They can perform surgery sitting at Tokyo, can operate in Sapporo. We can operate anywhere. So on interlinking, that kind of remote surgery feasible only in robotic surgery. That way, I think, and when India can afford a cheaper technology, easy way, and we should make it up. So this is where the artificial intelligence also can make it a different. So I thank you. If you ask me a question, is it conquered? Yes, but is it not full? Other way also. Why no? Limited surgeons can do. How can you say conquered? Majority of surgery in India and in the world, it is being done by open. So that unless more than 50% of the surgery is done by minimal invasive, so we cannot call conquered. Just because few surgeons are doing it and doing well, does not mean it is. So technically, technologically, it is conquered. But as a patient reach point, it will take time. Till that time, we are still conquering, fighting. We have to make every surgeon trained. Thank you, Rajesh. Thank you, Sunil Popat. And anything, I think Rajesh may have his own questions now. I'll be happy to share my views that day.
Sir, thank you so much. Sir. Thank you so much for once again a very, very inspiring lecture. I'm sure no surgeon in the world can ever get bored of listening to you and watching your techniques. The appetite always goes on increasing when we watch. And let me set the ball rolling. Meanwhile, we might actually get some questions on the chat. You've answered very many questions already, but it is important for the audience to have a word from you regarding what bothers the audience. So, and in your lecture, you mentioned the adequate experience should be there before a surgeon ventures into laparoscopic pancreatic surgery. What do you think what is an adequate experience for a pancreatic surgeon when he should start venturing into laparoscopic care?
Well, pancreatic surgeon always, particularly cancer, if they do, they should have a good open experience. Adequate open experience very important before going for laparoscope. And that is one thing. One is reason is, and same thing, radicality has to be complete. Safety of oncology has to be guaranteed. Second thing, and by chance, if he needs to have, maybe because of complication, because not able to proceed, he can do open and get it done. And for that sake, he can call somebody in a different city, come back, take over the case. One. Second thing, and this already dismal prognosis and the complications still high, duct leak and bleeding rate more, not properly done. That's why one should have experience. That means, if you ask me number of cases, how many number of cases one has to do, become experience, then individual. And how often he gets a case. Suppose if you say 30 cases in over 5 years, it is not correct. And 30 cases in 6 months or 1 year, it makes a difference. So that's why if we cannot documentally say, okay, 30 cases you can. Even some people 100 cases do it alone, they cannot do it. There are surgeons, even beginning 5 to 10, because open experience so much, and who has got laparoscopy experience other surgeries. So laparoscopy experience other surgeries plus open, put together he becomes expert. So one need not have a laparoscopic pancreatic surgery, laparoscopic everything in pancreas alone. And in India, we, Rajesh, every one of us, we do a spectrum procedures, not like Taiwan or Korea, Japan. They do focused organ. For them, they're difficult. For them, they say experience. Their experience is different. Our experience, straight away first case I could do it. Even in fact, after 2 cases when I presented my video in Japan, those people didn't believe. Then because seeing the video duct announcement, they said, no, you should have done large series. How can do in 2 cases you can show such a video? No? That's why in Tokyo they told. I said 2 only. Didn't believe. So that is why experience is individualized, depending on the experience.
Yeah. In fact, one of the prognostic markers, as we all understand, all major complicated procedures, or you can say major complex procedures, there is a volume outcome relationship. So we also know that if pancreatic resection is there or a liver resection is there, if it is done in a high volume center or with a high volume surgeon, the outcome is definitely better. This stands proven with the literature also. Now, one of the limitations for the pancreatic surgeons is if they are high volume pancreatic centers or pancreatic surgeons, they are all doing open. And they feel that if they venture into laparoscopic surgery, then probably their outcomes might get compromised. So, and I also personally feel that it is more of a, I would say, a mental block. How should a unit overcome that mental block? And I would particularly point my question towards, says there are so many good cancer centers, gastroenterology centers who are doing high volume pancreatic resections. But still, if you talk about high volume or not, say adequate volume, laparoscopic pancreatic resections, even in India, there are a handful of centers. And by that volume, I would mean, say, more than 10 pancreatic ripples laparoscopically. I'm not able to count at least more than maybe just about 3-4 centers in India. So what's your advice to these centers who are doing good high volume pancreatic resections with open and they are still hesitant to get into laparoscopic? What should they do? And what will be the incentive for them to get into laparoscopic?
Yeah, 2 things. Mental block. Just because doing high volume, they experience that. And the mental block, they no confident, they're moving on. That's the reason their people don't start. And they're starting it now, need not do everything every time skin to skin. High volume centers, they can do resection and reconstruction, do midline open, doing it. But step by step, they can learn. And if they have enough experience, yes, can do it. So that's why I brought the guidelines, what we call Coimbatore guidelines in the surgery oncology, step by step how to proceed. what type of tumor initially you can choose. Now, of course, we are all of us doing any indication for us same, open or laparoscope, no different. But in the beginners, smaller tumor, less than 3 centimeters, periambular tumors better, tumor in the head away from the vessels, and dilated duct systems, a dilated portal vein, and this common bile duct, and thin patients, and not overweight or obese. Like this, initially they have to choose and they should determine to move. All the centers, high volume centers, they are the people blocking even the surgeon doing it. But of course, now changing, they can't. In fact, I'm openly telling, I was punished because I was doing lab people. 1 year they did not give me DNB course. And if I don't know open, they may say, okay, right, I'm not training open people, so Palanivelu is not allowed to do DNB, fine. But I can do excellent way in open. I'm doing it. And that is the way the people 1 year. So this is a mental block of the high volume center surgeons thinking they are a good job, but they are not doing the good for the patient benefit. They are not doing. Now, of course, mindset changing it. But still a lot of people has to push. We will do it then.
Okay, sir. I think we are already running short of time because we have another lecture. One last question to you.
Yes.
Do you think carcinoma head of pancreas qualifies equally well for laparoscopic resection as do periampullary tumors? Head of pancreas.
Yeah.
Pancreatic cancers, yes.
Any tumor. Even including portal vein resection. Laparoscopy is the way to do it, then open.
Right.
It is.
Thank you so much, sir.
Surgeon's experience. That's all it mounts. Huh? Okay, nice.
Right.
Thank you very much.
Thank you. Thank you very much, sir. Once again, a very enlightening.
Everybody. Nice. So I'll be listening it anyway. And thank you. You can go to the next one. Thank you. Bye.
Thank you very much, Dr. Palanivelu, for a wonderful lecture. And so many times you and Rajesh discussed that it is mental block and nothing else. And you put it step by step so nicely that one more thing which you clarified, that it is the patient's right to get the best, and it is the surgeon's desire to give the best. So, as Rajesh asked, how to implement this laparoscopic pancreatic duodenectomy in teaching centers of pancreatic surgery, and you answered it nicely. But I think it is in the minds of the head of the department whether he wants to pursue it or not. And second thing is, in the beginning, it is a very good idea to do the resection and then open up and maybe do the anastomosis by open technique. And later on, you can have complete people's operation laparoscopically. My question to you, Dr. Palanivelu, is is it conquered? Because I know you and several others are doing for so many years across the country and abroad. But as you put it in the end of your lecture, it is still not widely practiced. So technically, the operation is conquered. But usage-wise, I think, as you mentioned, because every surgeon has a different experience and skill in laparoscopic surgery and in pancreatic surgery, it will probably take a while to make it universally available. What are your views on that?
Yeah, that is true. That's why now, initially 2000, when I showed video, it was something, it's a surprise for her. But till first 10 years, till 2010, few surgeons adapted in the world one by one. And even Kendrick started 2005 after seeing my video. But today he is the master, and that was. And Chinese guy started in 2011, Liu Rong. Now he has done almost 2,500 cases. So it is now slowly people accepted now. Now after some time, these people, if you don't start, they will be left out. So slowly that will change. So technology, technique, it is conquered. It is the superior to open. But since many surgeons not trained it, so that's why I said not done. So today we have to start proper training programs. One is awareness creating CME programs, subsequently hands-on training and mentorship, and then should have an advanced courses. So that has to go step by step. And probably the way people look at last 5 years, the way progress, next 5 years, it will go very well. And after 5 years, I'm sure any surgeon who say open, and people will ask, no, I will go to a surgeon who will do minimal invasive. And that way the surgeons all will come and decide shift. And it is a game. It is any procedure anywhere, the same thing will happen.
Okay. Last question, Dr. Palanivelu.
Yeah.
If a patient coming to you for surgery and affordability is not a problem, what would be your first preference, robotic or laparoscopic?
This is my own institute. If I love the subject, so that's why robotic I'm doing. And we charge the same minimal invasive laparoscopic robotic, same I'll do it if the patient is not affordable. Otherwise, as a teaching center, training center, we do open still, we do a laparoscopy, majority laparoscopy because we don't lose money. Robotic, if you go, that means 1.5 to 2 lakhs waste now. So selectively we do it. But the learning process, we did it, we know. And in fact, our robotic Whipple was the best one in Asia selected. It is fine, but I think it is cost-wise, for me, it is okay because I love it. Corporate, if you go, you can't. But government hospitals like AIMS and Jitmar, Rishikesh, or Algert, anywhere if you go, robotic surgery is free of cost. So surgeon is trained, he can do free. So it is 3 systems. Corporate, robotics too costly, and the institution like AIMS and this one is totally free. And government hospitals are private and general wards. It all again both being available. But our institute, like we are training teaching center, but not corporate. So we want to do laparoscopic robotic for training purpose and developing a technique wise. We do anything, but we cannot call over cost wise. We cannot talk because it is left to our own passion to doing it. Yeah. But somewhere there is we are able to make it a volume and getting it done technique, improving it. So India is something, it's a extreme, richest country, like giving a robotic surgery totally free of cost, unlike Western countries where it's too costly. But same time, same India and the poorest of people available. And so there they can't access because surgeons are not trained. I think it will always go. It's time taking. It will.
Yeah.
I'm sure next few years it will change that.
Thank you very much, Dr. Palanivelu, for the excellent lecture. I'll request Dr. Kanagwal to take this program forward.
Thank you.
Thank you, Sunil sir. Thank you, Palanivelu sir, for sharing your wisdom this evening in IAGS Prime Time. It's always been a pleasure listening to you. Ladies and gentlemen, now we move on to the next important aspect of today's program. The Master Laparoscopic Liver Surgeon, Dr. Senthil Nathan, the chairman of the GEM hospitals at Chennai and the head of the hepatobiliary surgery at GEM hospital, is going to address us. Before that, ladies and gentlemen, may I have the honor of introducing our trustee, past president, Professor Saindev Das Gupta sir, to the audience here. Professor Saindev Das Gupta sir has been instrumental in bringing in minimally invasive surgery to the eastern part of the country. He has started laparoscopic surgery as early as 1992 in Kolkata. After a brilliant undergraduate and postgraduate education from the Calcutta National Medical College, he has got trained at various places. He has had mentors from both national and international level. And in fact, to share with you, he has been instrumental in making India option of bringing laparoscopic instruments to reach of our surgeons. And he has been instrumental in various basic and advanced courses of laparoscopy of the IAGS from its time of inception. And then he has established and set the standards very high for these courses by creating perfect guidelines and teaching and training programs. Ladies and gentlemen, Professor Saindev Das Gupta has been instrumental in heading various bodies, various boards, various convenerships, and then he has been trend-setting in setting the academics in order over the past 1 or 2 decades. I have the honor of inviting Dr. Saindev Das Gupta sir to moderate this important second part of the program. Over to you, sir.
Thank you, Kanagwal. Thank you, Sunil. for inviting me to moderate this program. It is my pleasure and honor to introduce Dr. P. Senthilnathan, who is the head of the Department of HTB Surgery, Department of Minimal Access Surgery and Liver Transplantation in Jain Hospital, Chennai. Dr. Senthilnathan graduated from Coimbatore in 1998 and did his MS in General Surgery also from Coimbatore Medical College. He did his GNB also from Coimbatore, and then he did his MRCS in 2005. Then he did his GNB GI surgery from Jain Hospital in Coimbatore, and he got his FACS in 2011, FMAS. He is a fellow of Minimal Access Surgeons of India, and he is a fellow of the Association of Surgeons of India. He is presently divisional head, Department of Hepatobiliary, Pancreatic, Liver Transplant and Minimal Access Surgery, Jain Hospital, Chennai. He is an expert committee member. He is the treasurer of MRC, and he is executive committee member of ISG and also IHTBA of India. He has got numerous awards and achievements, which has a very long list, which I am not going to read out, but his academic qualifications and his achievements are many. So at his young age, he has achieved a lot, and especially in hepatobiliary surgery. It is my pleasure to invite Dr. Senthilnathan to give his talk. Dr. Senthilnathan, please.
Thank you so much, sir, for those nice introduction. It's my pleasure to be here in IAGS prime time to share some of my thoughts on laparoscopic liver resection. But before that, I'd like to thank IAGS President Dr. Sunil Popat, Honorary Secretary Dr. Ishramurthy, Convener Dr. Kanagavel, and all the office bearers and the executive committee members of the IAGS for giving me this opportunity. Really, I appreciate and thank all for this opportunity once again. The task given to me is laparoscopic liver resection. When, how, and why. It's always a humongous difficult task for me to talk after my mentor, Dr. Palanivelu, who has given a very good overview of laparoscopic pancreatic surgeries. Nevertheless, I'll try to do justice to my topic, how we do it, why we do it, and when we do it in this lecture. I'll share my screen. Yes. Good evening to one and all once again. My topic today is laparoscopic hepatic resection. When, why, when, and how. Before I start my lecture, today we just have the information that what we conceive, what we perceive that it is inconquerable, that is laparoscopic recipient hepatectomy has been published today. So that's a very significant development. What was unconceivable till probably a few years back was now possible, and at the summit lies laparoscopic recipient hepatectomy just got published. The case is from Korea. So really we are sitting on the top of what's called as a minimal invasive revolution with regards to the laparoscopic liver surgery. I bring greetings from Gem Hospital, Chennai. I'll take each and every question, that is why, when, and how. I'll start with why. In fact, I really love the topic because that suits the way I can present my case in a stepwise fashion. We all know laparoscopy, open surgery has got a lot of negative consequences. I'm not saying it's bad, but if you can able to avoid a larger scar, thereby resulting in weakening of abdominal musculature, and even sensory changes can cause significant disfigurement because liver is situated in right upper quadrant, either a big, generous midline incision or a rooftop incision or some of the fancy incisions like the Makuji incisions or inverted L-shaped incisions. All these incisions are liberal. It involves lengthier incisions so that disfigurement is cannot be avoided. But laparoscopy brings in potential advantages like faster recovery, lesser post-operative pain, less blood loss, and shorter hospital stay. These are very well found in the literature even a decade back. What I'm going to convince you is, one, the safety. People feel that laparoscopic liver resections are unsafe. No, it's not. On the contrary, it's very safe with equal 3 and 5 year survival rates. Not only that, about 80% of our liver resections are in the background of cirrhosis. Even in cirrhosis, the meta-analysis have shown that laparoscopy is safe and probably it favors, the resection by laparoscopy is favored because we no need to cut open the entire abdomen. Post-operative complications, bone-related problems, better management of ascites can be done with laparoscopic liver resections. Coming to the obesity, even in high BMI patients, laparoscopy offers potential advantages, and we have reasons, we have evidence for that one also. I would say it has got a great benefit both in cirrhotics as well as in obese patients for the obvious reasons which I mentioned earlier. And again, more than 80% of the liver resections are done for malignant lesions. And when we compare those parameters, including the survival outcomes, disease-free survival and the overall survival, both are equal with regards to laparoscopic and open. So no need to fear about the inferior work being done in laparoscopy. Margins are okay, margins are clear. We can able to additionally figure out the lesions. So even in malignancy, laparoscopy has got a lot of advantages. So this is about why I can say in a nutshell, oncologically sound, post-operative benefits, immediate post-operative benefits are there. And also it negates the negative consequences of a large laparotomy. Even it has got a lot of advantages in cirrhotics and in high BMI patients. Coming to the next pertinent question, when we should be doing laparoscopic liver surgeries? Can we do after lab program, or can we do after undergoing some basic training? No, it's not. It's a long winding road. If you look at our journey in lap liver resections, it's not made in a day. We started way back in 1990s with some non-anatomical or wedge resections. Then we learned how to do a segmentectomy, especially the peripheral segments, segment 2, 3, and 6. Then we go to the bisegmentectomy, like the left lateral segmentectomy. Then we graduated to do a major hepatectomies, like the right and the left. The left is simpler compared to the right, though it's not, it's still difficult, but left is doable. Right has additional difficulties. Then major hepatectomies against the cirrhotic background. Again, we need to put all our efforts in doing that. And finally, because of all our efforts, culminated in doing laparoscopic donor hepatectomy 3 years back. It's not the road, the journey is long and winding road. It's not made in a single day. And that is possible with our concerted effort in non-resectional surgeries to start with. We started with laparoscopic hydatid surgeries, then ventured into major hepatectomies. Transplant unit was set up later. Initially, again, in transplant, as far as the donor hepatectomies, we never ventured directly. We ventured into hybrid approaches, initial mobilization by laparoscopy, parenchymal transection by open, and then we graduate, and then we know how to do the pure laparoscopic donor hepatectomy. This is how we have to climb. It's like climbing a Mount Everest. First, we have to acclimatize. First, we have to have the gadgets. Then we need to do all the base camp. We have to go to the base camp and then the summit. Likewise, we need to have a lot of steps to progress to achieve pinnacle in laparoscopic liver surgery. I can show this is in 2006 and 2014, our results on laparoscopic hydatid surgery. Though it's a non-resectional predominant procedure, still about 10% of those hydatid surgery at the time required resection. So that is how we got to know how we can do laparoscopy for tumors. Then after a decade and a half of experience with laparoscopic surgery, we published our first of the series of laparoscopic major hepatectomies. Both only right and left were included, 56 patients with excellent post-operative outcomes. We also did our background check with the laparoscopic radical cholecystectomy, because that also involves removal of two segments, segments 4B and 5, so that what's important is we should familiarize, we should be able to train our team, and that has culminated in being invited for the Asia Pacific Expert Committee on laparoscopic liver resections. This is all, again, I stress, is made possible because of the efforts of the team, concerted effort over a long-term period, so that we can able to develop and run a successful laparoscopic liver unit. And then coming to the starting of the procedures, we should select solid lesions predominantly in the peripheral locations. Perhaps we can choose a non-cirrhotic background. These are, to some extent, will help us in get to know the finesse, that nuances associated with laparoscopic liver resections. And the tumors, again, should not be more than 5 centimeters. So we should choose to pluck the tumors which are easy, which are lying pedunculated, which are easy to grab. Then we can go for some deep-rooted tumors. As I told you, peripheral located tumors like here can be tackled initially, and then later we can go for deep tumors. Once we have enough confidence, learned team, we can go for masterclass procedures like right anterior sectionectomy, right posterior sectionectomy, central hepatectomy, caudate lobectomy, and finally, I would say, culminate in what's the summit, achieving like the Mount Everest, which I would say donor hepatectomy. Perhaps now we have the recipient hepatectomy also. So this is again, this I would say I have graduated to know how to do the hanging maneuver. Before, personally, I went into donor hepatectomy, because safety is important. I should know when to, every time, all the time, throughout the procedure, I should have a proper control. So hanging maneuver is one such thing where I graduated later in my career, so that I can do donor hepatectomy successfully. Of course, Dr. Palanivelu didn't have the need to do it, but I somehow felt that I should have a proper control in the retrohepatic or on in front of the IVC, so that whatever happens, everything can be in our hand. Again, this is again can help in final parenchymal transection. As you can see, always we have a real insurance, a real confidence that something is behind to protect us, not to injure the IVC. So I learned this as my last step in achieving the laparoscopic donor hepatectomy pinnacle. As a result of our effort, we published our first series from India, It's a small. Now we have crossed to 25, but at that time it's short case series of 3 patients, which was published 3 years back. Then coming to the all the more important, how to do. What is the technical relevance? What are the technical know-how of how to do a laparoscopic liver resections? Very important point. That's why I kept it as the last section of my talk. One thing, Dr. Palanivelu sir also stressed the need for having a proper camera trocars. Camera is not in the midline. Like in pancreas, we shift the camera towards the right lateral position because the porta is not in the midline. It's not a midline structure. It's situated well away onto the right side. So that's we have to understand, and we have to place it accordingly. The rest are all retraction and the working trocars. And here I stress on one important point. We need to compartmentalize the job to the other members of the team. Like the camera surgeon, the surgeon stands between the legs, the camera surgeon stands on the right side, the assistant, the first assistant or the first surgeon stands on the right side, and then the scrub nurse can be behind. Or maybe we can have one more assistant here, and everyone should be given proper space, proper instructions to manage what all the jobs they have to do. They have to retract the liver, yes. They have to suck the fluid, yes. They have to retract the gallbladder, or they have to give clips, or they have to assist. Each and every member of the team should know what they are doing so that the surgery goes seamless. Then it starts with after mobilizing portal dissection. This is for major hepatectomy. Have a beautiful demarcation line. Go for the parenchymal transection, the key aspect of laparoscopic liver resection. Unfortunately, we don't have Kelly clamp in laparoscopy, so we have to resort to some sort of energy sources. And we among the lots, what I prefer is QSA, because that brings the parenchymal transection closer to open rather than mass coagulation and just keep on cutting, which I don't do nowadays. Initially, I was doing like the Habib probe, cook and cut, but now we just identify. Then we do the outflow control using staplers. And finally, the cut surface is inspected for any bleeding or by leak. Again, I love this concept of symphony orchestra being played to a theater. Likewise, liver resection is also played to perfection with help push from not one but many people surrounding the operation. Of course, the surgeon is at the center, no doubt about it. He or she guides the procedure, but others, like the instruments that's played at the symphony, have probably equal important, if not more important role. Why I say is multiple roles are played: retraction, suction, instrument exchanges, proper camera work. Everything has to be perfect. It may not be so well. We can manage with the beginner for other procedures, but not for laparoscopic liver resection. The next concept I would like to tell you and also follow is the excavation concept. Like we excavate all the ruins, all the archaeological ruins, which we, the ASI do. I mean, ASI means Archaeological Society of India do. We need to excavate, excavate the liver so that all the hepatocytes are defragmented, and what is made out is the biliary radicals and the blood vessels, which can be tackled easily. Other thing is bottom-up approach, because we look from below up, not from top down. So we go from bottom to towards the main vessels, so that like an open book, we should know what exactly happened at the transection plane, so that any eventuality can be tackled. And technology helps a lot. I'll just show from now onwards. I'll be playing few videos and then wind up in the interest of time. Technology, especially the ICG, as you can see, beautiful parenchymal transection planes are well made out, not by just visual. I mean, here again, the second video, when initially it was blue, now we have ICG, indigo sign in green. Hemiportal clamping for both donor hepatectomy as well as for right and left hepatectomies. Hepatic artery and hepatic portal vein is clamped. As you can see, this is the right hepatic artery being clamped. Portal vein is already clamped. and then switch on the ICG mode. You see, initially it's all not so clear, but the moment we switch on the ICG, you see in a few moments, you'll have a beautiful demonstration of hemiportal occlusion as well as perfused liver. This helps us a lot in our planning so that exactly there will not be too much of wavering of the parenchymal transection plane this way or that way. Not only that, bile duct identification. Leave the main bile duct, even accessory. This is one of the donor hepatectomy videos where the donor has accessory bile duct. Very difficult unless you have an intraoperative cholangiogram, which is cumbersome by laparoscopy. And here you can see, but the switch, click of the button, we can see beautifully the presence of accessory about 3 millimeters. This is the accessory bile duct, a small duct though, still we can able to identify and preserve, and then which can be tackled later. So ICG and technology helps us in not only in bile duct identification, but also in resection. Now, I'll show a couple of ICG based videos. This patient underwent a anterior resection, had a colorectal mets. I did segment 4 resection. You can see that's why it's all adherent. 2 times. This is the 3rd resection. And 3rd resection, we have segment 4 again, 4A. Multiple re-resections are all possible with the help of laparoscopic ultrasound probe. We can see diaphragm is attached. We have initially at the end removed a chunk of diaphragmatic portion attached. Then we mark it, and then we can surface marking alone is not enough. When we go in with the help of surface marking and the ultrasound guidance, we can go for the inflow control first. That's what we are searching here. This is intraparenchymal inflow control. So cues are being used. As I told you, it's an excavation concept. We need to excavate so that these small biliary radicals, this is a vein, outflow control can be tackled. So there should not be any slogging. Slowly, we should make our way. Everything. This is the inflow control. Because of the excavation concept, we could be able to do the inflow, and then silk is tied around. And then now you can see once the ICG is injected, we can see a complete demarcation. That means it's not only bloodless, but also oncologically safe. So this is what the technology has given us. We have traveled a long way by just simply marking the surface and then doing 2 segmental resections based on the ICG. So the inflow then is divided, then we go for the outflow, and then we remove the proper anatomically removed segments. The next one is segment 2 resection, again based on the anatomy ICG. Here again, you can also see how a surface marking can be modified based on the ICG. So the triangular ligaments are divided. You can see the tumor here, segment 2 resection. Surface marking is done. As you can see, later I'll tell you how a surface, the tumor is here. Generally, it's about half, segment 2, segment 3. Then we proceed to the inflow control. We have not started dividing the parenchyma. This is extrahepatic Gleasonian approach. At the umbilical fissure, you can see this is the umbilical fissure. We dissect and then go to the segment 2 inflow pedicle. This is segment 3, and this is segment 2. This is segment 3. Now we can see because of this is extrahepatic Gleasonian approach, we can able to go and then identify individual segmental inflow pedicle. This is, you can see, endomini retract, And segment 2, a little bit of parenchymal transection needs to be done. With the help of endomini retract, we identify, encircle the segment 2 pedicle, and you can see how we have gone wrong. This is exactly the segment 2. Initial surface marking was modified, and this is the true segment 2. Somewhere we went more, somewhere we went less. And this gave us exact, segment 2. Then we remark the surface and then we proceeded. This gives proper anatomical segmentectomy. Now we can see on all sides, we can able to do a proper segmental resection. Once we mark, then we clip the inflow control, inflow pedicle. So this is how our technology again helps us to do proper segmental resection. In the same case, I would have erred some way more and some area less, so that it may not be a true anatomical resection. But this has given the true anatomical resection. As you can see, rubber bands, as Dr. Palanivelu has shown, can be used to retract on both sides of the liver parenchyma like an open book. Then we proceeded. It gives a nice traction, controlled traction, so that now we use it not only for uncinate resection, but also for parenchymal transection in liver resections. So then we proceed. Everything is in our hand. We can have a roadmap. Inflow is done. We need to do the outflow only, and that's proceeding smoothly, no slogging, so that our heart rate will not increase as we progress towards the outflow control. This is what I said, excavation concept. It beautifully gives all the structures, the framework of the liver nicely, so that we can tackle it. You can see this is the outflow. Outflow is clearly seen nicely, so that we tackle it with a stapler, and then we remove the proper anatomical segment 2. This is at the end of segment 2 resection. Yes, technology definitely helps. A couple of videos and then I'll stop my presentation. Right hepatectomy, coming to the major ones, mobilizing the liver, and then we come to the right portal dealing. So that first we do the hepatic, portal vein and the hepatic artery. This is the hepatic artery being looped, ligated and divided. Then we go to the portal vein. Pringle ready, we should be Pringle ready. There was a small bleeding because of the the caudate branch. Then we should be Pringle ready. A short Pringle usage can reduce the bleeding. Then you can see the portal vein is soft and supple. It's encirculated with again endomini retractor can be used. It's ligated in continuity because the space, the extra hepatic space available sometimes may not be adequate for a clip. Remove the Pringle, then we start parenchymal transection after surface marking. Again, like an open book, retraction on either side with the rubber band or the sutures. Initial parenchymal transection is by harmonic shears. And then for deeper parenchymal planes, we use CUSA. Left hand is with bipolar forceps, Maryland type of bipolar forceps. This is the origin of the middle hepatic vein forming between the V5 and V4. We divide that, it's V5. Again, no slogging. Then we go deeper into the parenchyma. We see the inflow control inflow. This is the pedicle, the right anterior segment, and then individually forming the segment 8 portal pedicle and segment 5 portal pedicle, forming the right anterior here. So again, we are going away from the porta, so we are very safe. We could able to do in a very relaxed manner. So this is segment 5, then segment 8, and finally we have the right posterior pedicle, again away from the porta, along with I can see caudate lobe. So this is right posterior. Finally, we come to the portal right hepatic vein. The tumor is below, so that even tumors situated in the perihepatic areas can be tackled without the need to slog, without the need for much of a bleeding. Staple division using white cartridge. And finally, we can see the IVC is in our view. The IVC is here, and this is the Makuchi ligament or the IVC ligament being divided, and then the tumor is removed. The final bit of tissue, you can see the IVC, the subarachnoid region. So this is about through a Fannin incision. After putting it in endo bag, we just remove the final. I just again, this is, I would say, the pinnacle, that is laparoscopic donor hepatectomy. A part of it you've already seen. Mobilize the liver, mobilize it widely, and this is what I said: the hanging maneuver, the retrohepatic fashion, so that we have a lot of comfort. Then individually, we go for the hemiportal clamping after dissecting the right portal vein and the right hepatic artery. Surface marking, then release the surface marking and start parenchymal transection. Similar to the resection, but only thing we need to identify the inflow as well as the outflow. V5, V6, what are all the venous outflows which needs to be reconstructed, they have to be preserved. In the interest of time, you can see this is clipped and divide. That's going, that the V5 is going to be reconstructed. Slowly we'll be going to the V8. V8, this is V8, as you can see. This is this also will be reconstructed at the back bench. And now we do what is called the hanging maneuver, excluding the porta, so that only the parenchyma is left. Below is the IVC. We use generously the ICG throughout the procedure. The bile duct is divided first, as you can see. First, this is the V8. Then the artery is hepatic artery is first is bile duct, hepatic artery. Bile duct, you can see bile duct is divided. Then we are ready with the retrieval of the graft. Hepatic artery is divided. Portal vein. And finally, the hepatic vein. So all these are divided. Now we have one-sided stapler. This is the IVC ligament. So we divide and then remove the graft. So this is my suggestion. Start with minor resections. And this is not only mine, there is a consensus, the second international consensus conference on laparoscopic liver resection in Ubate. It also states that assess the difficulty preoperatively, hybrid techniques in difficult situations, along with the cautious use of energy sources. So to conclude, I would say that as far as the laparoscopic liver resections are concerned, now the standard of care for minor hepatectomies is laparoscopy, no doubt about it. Major hepatectomies, even in 2021, are limited to few centers for the technical difficulty involved in performing laparoscopic liver resections. Better perioperative outcomes with laparoscopy and equal long-term results with compared to open surgeries. I can say that technical refinements, especially with the wider availability of CUSA and better understanding of the anatomy, as well as usage of energy sources and technologies like ICG, now laparoscopic liver resections bring parenchymal dissection closer to open surgery. Thank you very much.
Dr. Saindar, sir. So please
I'm
unmute
very
yourself.
privileged to have the comments from Professor Saindar, sir.
Can you hear me now? Can
Yes,
you
sir.
hear me now?
Yes, sir.
Thank you, Dr. Satyanathan, for an excellent presentation. You made everything look so easy. That is an indication that you are such an expert. Excellent presentation. What I want to know is what is the acceptance of laparoscopic hepatic resection in India? How many centers are doing it, and how many people are accepted it?
Sir, if you, I don't know if you allow me, I will.
Yes.
I did a study, sir, for my Wuhan, in the sense when I was selected for the Asia Pacific Expert Committee membership. I presented Indian experience, and then this is what I have to present. I did a study. So that's the only Indian study that is available. I will just quickly present it. Shall I share my screen?
Please.
Yes, please, sir.
Yeah.
Please do.
This is the presentation which I made in Wuhan, the epicenter of coronavirus, few years back. So this is the Indian scenario. We have sent a set of questionnaire to 47 centers who are doing laparoscopy and open. There were 38 responders, 19 doing laparoscopy, 19 they don't do laparoscopy. And their preferred approach is total laparoscopy. And indications, again, hepatoma, it's all mixed, including the symptomatic benign or indeterminate tumors. Pringle, they do, they predominant of the people, they say they use selectively the Pringle maneuver. Parenchymal transection technique used, yes, about 50-50 for multiple and CUSA. Difficult areas are porta dissection, transection, bleeding, outflow control, and suprahepatic IVC control. Main reason for conversion to open is bleeding, which is very obvious. So this is with regards to your question of what is the Indian experience, the centers which are doing laparoscopy, sir. This is the only. Unfortunately, I have not published till now. Probably I should be publishing these results. But
Yeah,
the question is.
No. What I wanted to ask was, how many centers are doing laparoscopic hepatic resections compared to open ones?
Okay.
Most people
I got your point, sir. It should be less than 5%. The penetrance of laparoscopic liver resection, I would say, is even lesser than pancreatic resections. Pancreatic resections, distal pancreas, there are a lot of people are doing. Whipples, yes, now increasing, but liver, there is an inherent fear of bleeding, inherent fear of embolism. That's why I would say probably the others can also give their answers. My, expectation is less than 5% of the centers. I'm talking about centers who are doing good quality HPV work. They only less than 5% venture into laparoscopic liver resection.
Because as I understand, most of the HPV surgeons look down upon laparoscopic hepatic resections. They actually look down upon. I mean, there is no evidence to it, but the general concept is laparoscopy is inferior to open surgery for hepatic resections. That is my impression that I get from other centers. My next question would be, what are the outcomes? How good is the outcome? Because you don't have a very large study. No? The study, what you are presenting is very limited study because the number of patients is low. And the open dissections, open donor dissections, their volumes are much higher. So what do you think is the outcome?
Now we have a good randomized control trials. Oslo COMAT is the first randomized control trial that has got published, and that shows that compared colorectal liver mets open versus laparoscopy, that has compared both arms. Reasonable, it's a first randomized control trial. Not only that, subsequent multi-center as well as multinational trials have shown that laparoscopy is at least as good as open with regards to the oncological outcomes, with the additional benefits of immediate perioperative outcomes. So that's what the literature-wise, it's all clear, sir. Both with regards to cirrhotics, as I mentioned, with regards to oncological, it's not about few cases. It's the few cases is about our experience. It's about now we have crossed 250 resections, of which about 70 odd is major hepatectomies. I would say ours is not a great numbers, but when you look at the literature, we have evidence comparing about 1,000 hepatectomies here, 1,000 hepatectomies there, even from the good centers from US, published in the Annals of Surgery, from MD Anderson and the other centers across, including Mayo Clinic, have published, Nguyen has published 1,000 laparoscopic hepatectomies without mortality. That's what the literature says. Now, if you ask literature, yes, sir, definitely there is a case for laparoscopic surgery.
I think what you have shown, all the videos that you have shown, the ICG and technology has made a big difference in the outcome of laparoscopic hepatic resections. Do you think that it is a paradigm shift in? Do you think that is a paradigm shift in outcomes because of the advances in technology, especially in ICG?
I think so. So personally, I think so. That has improved personally my margins. I can be more confident about my margins, so that what I previously perceived as a good anatomical resections, now I have the ability as well as I can confirm it on table. Am I doing a proper segmental resections? Because proper segmental resections always will have a better oncological outcomes. Whether it is bisegmentectomy, monosegmentectomy, bileaks are less, bleeding is less. So my technique has improved, my confidence has improved with the advent of ICG. Not only for one reasons, but for multiple reasons, including bile duct identification, hemiportal clamping, as well as in this is a negative staining. Generally, we do a negative staining where the rest of the parenchyma illuminates and the segment which I am going to resect gives a dark one. So yes, I agree to your point. Personally, our results have been on the rising trend, so that we have not only more confidence but also on table identification is now possible, sir. Yes, I agree. Technology definitely helping. Two technology. One is ICG, the other one is QSA. QSA and third one is laparoscopic ultrasound. These three things will help us in mapping, doing a proper surgery by laparoscopy.
What do you think will be the role of robotics in hepatic resections?
Very much. I restricted myself to laparoscopy because the topic is laparoscopic liver surgery. Yes, robotic definitely has a role because unlike other surgeries, this has a fixed area of working. We don't need to, after portal dissection, we just stay on the course throughout the entire parenchyma transection in one frame. And also when we go into the superior aspect, laparoscopy, flexi tip, all those cameras, 3D laparoscopy, flexi tip, along with the robotic place gives a stable platform with which we can work a lot more comfort. So probably it's a new chip of the whole block. Robotic surgery definitely helps, probably augments. It may not completely replace the laparoscopic surgery, but yes, robotic surgery is probably the one another reason why more and more people are embracing minimal access, because transition from open to robotic is easier than open to laparoscopic surgery. For that matter, laparoscopic to robotic, unless there is a busting need, real need, probably people will continue laparoscopy. So the best chance for any open surgeon to learn minimal access, I would say, is robotic surgery. It will have definitely a good impact on the way with which we operate in the future.
Thank you, Dr. Senthilathan. Because we are short of time, we are almost finished. For your excellent presentation, and I wish you all the best for more innovative surgery for laparoscopic hepatic resections and hepatic surgery, hepatobiliary surgery in the future. Thank you very much.
Thank you so much for the nice words. Thank you for moderating my session, sir. Privileged.
Rajesh has a question.
No, I have a comment. Excellent presentation once again, Senthil. That was again very, very interesting. Lots of good videos. And I would just like to support and reiterate your views for the audience that laparoscopic liver resection is the way to go. I've been to centers in China wherein they do 40 liver resections in one department in 1 week. And I've seen about almost 6 to 8 per day very swiftly by almost every member of the department. And I very strongly feel, having ventured into one, we are into laparoscopic liver surgery for the last 4 years. We have a decent experience, and I would urge you to include our center also when you try to collect the data and publish it. I strongly feel that laparoscopic liver resection is probably much more standardized and has much better results in terms of outcome and ease of technique when you compare it to laparoscopic pancreatic surgery. Perhaps routine pancreatic laparoscopic surgery is probably slightly more challenging than routine laparoscopic surgery once the learning curve is crossed. And I think that's the future for liver surgeons.
Yes, well said, sir. Thank you so much.
Thank you, Senthil, for excellent lecture and excellent videos. Rajesh had one question which he posted in the chat box. Rajesh, do you want to ask it?
Yeah. I just wanted to know your preference for the timing of ICG injection as per the intended use. So when do you inject ICG? In what scenario? What are you trying to look at? And what is the timing of injection?
Yeah, if it's a very good question, sir. If it's for vascular reasons like hemiportal clamping, segmental resections, it has to be immediate, instant. You clamp the inflow and then you give it, then it gives a nice demarcation. It has to be instant, like an arteriogram, like a contrast enhanced CT. You do all the things, all the clamping, then give ICG. It's very simple to understand. But if it were for biliary anatomy, we have to give full 2 hours before the procedure, so that everything then will be concentrated onto the bile duct. Otherwise, what happens? There will be smudging of the images, because the liver filters the ICG from the blood through the hepatocytes, and then it just filters into the bile. Immediately, the blood vessels, the liver parenchyma, as well as the bile duct, everything will be in one image. There will not be much of a difference, like DSA. Later, 2 hours, 3 hours, because we have seen in the transplant setting, at the beginning of the surgery, we give. 4 hours later, that shows a nice, beautiful anatomy. So for biliary purposes, at least 2 hours before. For vascular purposes, instant. And for some, the third reason is to identify, to pick up additional liver lesions. We need to give a few days before the surgery is done. So these are the 3 indications for which differential timings are followed.
Thank you so much. Thank you.
Thank you, Chair, and I'm sure we can go on. We can go on discussing for another few hours regarding laparoscopic hepatic resection, but you very well summed up how one should start the laparoscopic liver resection and how one can proceed. I had one question that I think you were doing laparoscopic liver resection before even the advent of ICG. So I think at that time you were guided by laparoscopic ultrasound, or you had any other tricks?
Yes, sir. If it is not an inflow like extrahepatic or glyconian, or 2 things, anatomical landmarks. See, in segment 2 and 3 or left lateral, falciform is very obvious. We cannot go wrong. Where we go wrong is on the other side, where we don't have a clear anatomical demarcation. There we use laparoscopic ultrasound, no doubt. We use it, the marking. Say for example, segment 4B and 5. We still do by laparoscopic ultrasound between the segment of 5 and 6. Sometimes it can go wrong. Now retrospectively, when I just after usage of ICG, now I'm going back and thinking whether all my previous, it's not the case with it's not the case with hemi liver resections like right hepatectomy or left hepatectomy. For segmental based minor resections like bisegmentectomy, ICG comes. Probably all my previous, I don't have the answer, but may or may not be correct. All the previous bisegmentectomies and the segmentectomies. Now I can clearly map it. Yes, for that reason, I'm using ICG to a great extent.
Yeah, thanks. Another question is, when you moved from open liver resection to laparoscopic liver resection, has it increased your resectability that previously you were not resecting some of the liver lesions which you are now able to resect because of the gadgets you have now available with the help of laparoscopy?
No, sir. This I would like to, if it is picking up additional lesions, yes, laparoscopy, we have a laparoscopic probes. Of course, we have open probes also. Leaving that aside, this is one area where if I cannot do by laparoscopy, I can do by open. That is my answer, because large lesions. So I'm very passionate about laparoscopy, no doubt, but at the same time, I cannot vouch I can do laparoscopy for all tumors. Tumors which are very large, tumors sitting very close to the hilum, tumors which are sitting very close to the IVC. So all these tumors, I mean, again, central hepatectomies, though I say literature-wise central hepatectomies can be doable, but still lot of limitations are there. Lap, if not for some reasons, open for large tumors. That's my answer.
Yeah. Thank you, Senthil. Thank you so much. I'll leave it to Dr. Palanivelu to take this program to its conclusion. Thank you.
Thank you, sir.
President. Senthil sir, one last question to you before we close the session. Do you think probably like how gallbladder has been totally taken over by laparoscopy and dental access, do you think probably the next generation younger surgeons with more advent of gadgets and assistance, liver resection will see its time towards laparoscopic learning, or you still feel a definite open experience is mandatory before taking up laparoscopic liver resection?
No doubt. This is a very valid point. Closing remarks, open surgical experience is very, very valid. Without having proper open experience, this is, I would say, coming together of the both of the worlds, best of the both worlds. A very good laparoscopic skills with a very good background of working in an open surgical setup. Because when laparoscopy is not working, we have to fall back on open surgery. At the time, I cannot say or call somebody to open and then manage. No, it cannot be done. We have to manage whether in open or laparoscopic surgery. And ultimately, when everything else fails, probably we have to fall back on open. So open surgical experience cannot be compromised. That is a basic minimum for us to venture into laparoscopic surgery. And to a point, laparoscopic cannot replace completely the open resections in these kind of major procedures. What we try to aim is to increase the proportion of the laparoscopic surgeries from, I would say, now from 5% to probably 50-60%. That's it. It can never replace open surgery, at least in our lifetime. That's what I feel.
Thank you for very pragmatic, Dr. Senthil sir. And may I now have the honor of thanking Sayanda sir for excellent moderation of this session. Thank you, Senthil sir, for sharing your wisdom this evening. With the permission of the President, can I invite Ishwar sir, our Secretary, to propose the vote of thanks?
Thank you. Thank you, Mr. President, Dr. Kanagavel for conceptualizing and bringing a wonderful program today for the prime time. I'm sure all the viewers of Doc Plus would agree. They had a really absorbing 2 hours of academic treat. I think what a sight to witness. 2 mice, I would say, in their own right, in the world experts in liver and pancreas, giving the pearls of wisdom. I think great presentation, excellent video quality, and we are all very proud and to present our words of appreciation and appreciation certificates both to Professor Palanivelu and my dear friend Senthilnathan for wonderful presentation. We thank both our past president, Dr. Saindra, and also the EC member and the CELSI UP president, Dr. Rajesh Bojwani, for moderating the session, keeping the time up. And thank you, sir. And it's been always a motivating figure, like leading from the friend. The whole Indian scenario is waiting to know more from you, also your team in GEM Hospital, to Senthilnathan, and all the people doing a wonderful job. And as office secretary, I have a couple of pleasant duty news to share with all of our 8,000 odd members across the country. As you all know, this week we are very academically vibrant with yet another program happening on 4th September. Please watch the time, 5 p.m. onwards, on ventral hernia. With lots of national, international figures are joining for a master class on ventral hernia. And as you believe it or not, I think we need to take it. The COVID is fading. It's a time for all of us to meet on site. I think we had enough of online. So the first program we are going to meet in Delhi on 10th to 12th September. Thanks to our Randeep Wadhwan, our EC member from the North Zone. He is hosting the false upper GI, and we are going to have a wonderful program. Followed by Kanagavel himself, along with his colleague Balaji Singh, is going to invite a double bonanza of FAGS and EFAGS, the flagship programs of IAGS happening. I'm sure all of us know the hospitality of Chennai, and I'm sure with the people from Sendil and all our, I think Praveen, all are going to be there along with everyone to make it really an academic treat. So we welcome wholeheartedly all the members to join, because here there is a one unique thing is happening, because even though we are starting the first on-site program, there are quite a lot of online candidates are awaiting their assessment. So they're all quite welcome, and please talk to or at least write to Dr. Kanagavel so that you will be accommodated on, note the date, 25th and 22nd. That is a day 2 and day 3 for 1.5 days with no additional registration fee, and your assessment will be done and you will be offered the hands-on experience in whatever you want, whether it's an endoscopy or a simulation in the laparoscopy setting. So that's the news I want to share. And also there are more news are going to come. I think we are going to have false colorectal, as I said, Praveen is going to host in GEM Hospital, Chennai, and then we need to travel all the way to the south end of our country, Kanyakumari, to witness Siva hosting false hernia. Lot more to see from our friend, I am sure, when we meet next year beginning, that is in February 10th to 13th in Rajamundry. I am sure we are going to have a wonderful on-site congress. As we speak, this weekend we are going there to make sure all the arrangements are done in a great way. So, ladies and gentlemen, you all know we have been active in the last couple of years in a various front, seat, COVID task force, online fellowship, or now the on-site fellowship. Equally with the Dr. Ramesh Agrawala and his team working day and night to get the IAGS research committee vibrant with a first large prospective study on inguinal hernia. People interested to join here as a collaborator, please talk to Tarun Mitchell or Dr. Ramesh Agrawala or myself to join the study. And also we'll be sending a notification regarding applying for the best JMAS journal article or researcher and also PG thesis award also, and I am sure people will be interested to apply, and we are all making all the initial efforts to make our association also with the collective efforts from our colleagues to make an India in the world map in the World Congress 2024 in Kolkata. So with all these things coming, and we'll keep you all connected with YouTube channel. Today's program, if people missed it by any chance, is a wonderful 2 delightful lectures. You can watch it in the IAGS YouTube channel for several times, and also it was telecast today also in the Facebook page. And soon, I think it's a matter of days, we are going to have the mobile app also ready. So a lot of good news to share. Until we see you again in the prime time with yet another beautiful session. Thank you, Doc Flusses, for a very excellent transmission today. And thank you, President. Thank you, Palanivelu, for yet another program. And we thank both the speakers for having stayed late today with a busy schedule. And thank the moderators. Bye-bye. Good night. Jai Hind.
Thank you. Thank you, Senthil. Thank you, everybody.
Thank you, sir. Thank you so much.
Thank you, everyone. Thank you, Dr. Plexus. Thank you, President. Thank you, Secretary, sir. Thank you, Sayendra, sir. Palanivelu, sir. Thank you, Senthil, sir. Good night. Thank you, everyone from the Dr. Plexus also. Rajesh, sir. Good night, sir. Bye. Bye, everyone.